Without further ado, so as you all know, asthma is a very common disease. It affects over 260, some would say 300 million people worldwide. In the US alone, there are 25 million people with asthma, about 6 million children and 19 million adults. Those are 2021 estimates. It is the most common chronic respiratory disease in children worldwide, and it poses enormous cost to the healthcare system. But this is from about 10 years ago, where it was estimated it costed $81 billion per year. The picture shows an airway of somebody having, an asthma attack, status asthmaticus. And that shows some of the characteristics of asthma. Asthma is characterized by airway inflammation, remodeling of the airways, hyperreactivity to non-specific stimuli, and airflow obstruction that is often but not always reversible. The one phenomenon that has called the attention of many people over the last 20, 30 years is how rapidly the prevalence of asthma increased from a period that probably started in the 1950s or 1960s to, in some countries, the 1990s, when it plateaued. In others, this phenomenon continues to occur. That is, the prevalence keeps increasing. Such rapid increment in the prevalence of asthma cannot be explained by genetics. The rate of mutation in humans, about 3 mutations per generation in the absence of a catastrophic event. So something had to change in the environment. In parallel with this asthma epidemic, the other thing that has changed is our diet. Over the last century, residents of middle to high income countries started to adopt a diet that often includes highly processed foods, saturated fats, coupled with low intake of fresh fruits and vegetables. This change in dietary habits has been hypothesized to at least in part explain the asthma epidemic in countries with a so-called Western lifestyle. So let's first talk about vitamins and asthma. So a vitamin that gathered a lot of attention over the last decade or so was vitamin D. In humans, most of our circulating vitamin D levels come from sun exposure. UVB light is processed in the skin. We also get some from our diet. This metabolized in the liver, and what you measure in blood is 25-hydroxy vitamin D. Then in the kidney, this is further metabolized to the active form of vitamin D, or 1,25-dihydroxy vitamin D, which for many years, and this is a slide from a paper in the New England Journal, has been shown to regulate calcium phosphorus metabolism and bone health. However, people started to make the observation that vitamin D insufficiency, low vitamin D levels, and asthma has some common risk factors. That is, obese individuals have a higher risk of asthma, and they also have lower vitamin D levels because vitamin D is lipophilic. Two groups that are disproportionately affected with asthma, African Americans and Puerto Ricans, have higher prevalence of low vitamin D levels. And then migrants from low income to middle, high income countries also have higher prevalence of incidence of asthma and low vitamin D levels. And of course, residents of urban areas. Then there were a series of observational studies. These are meta-analysis of birth cohort studies. And you see here 4 birth cohort studies with reasonable sample size conducted at different parts, at different times in different regions of the world, showing evidence of a potential protective effect of vitamin D. In fact, 45% lower odds of wheeze, which is a major asthma symptom by age 5 years or at age 5 years. So it was hypothesized at the time that perhaps vitamin D supplementation may have some protective effect also on asthma exacerbations, perhaps by reducing the risk of viral infections or their severity, downregulating T2 immune responses, and potentiating steroid responsiveness, therefore having a potential protective effects. So there were 2 major trials. The first one, the vitamin D antenatal asthma reduction trial, or VDART, was interested or tested whether vitamin D supplementation during pregnancy may protect the offspring of these mothers who took vitamin D against wheeze and asthma. So what was done in the first trimester of pregnancy, 440 women were randomized to daily 4,000 units of vitamin D, plus a prenatal vitamin that had 400 units. So they got 4,400 total international units of vitamin D. And a similar number, 436, were randomized to a placebo plus a prenatal vitamin with 400 international units of vitamin D. And then initially, the children were followed from birth to ages 3 and 6 years. And what they found, and this was published in the New England Journal in 2020, was that there was no significant effect of vitamin D supplementation on asthma or recurrent wheeze in the offspring at age 6 years. They also had not found anything at age 3 years. I showed the summary of the results at 6 because that's when you can more confidently diagnose asthma in children. In parallel with this, there was another trial, COPSAC, in Denmark that also found similarly negative results. It was a smaller study. We were interested in whether vitamin D supplementation could prevent severe asthma exacerbations in children with low vitamin D levels. This was an NHLBI-funded study. We recruited kids from June 2015 to September 2019. There were 6 sites for this trial. And what we did was we studied high-risk children. They had mild persistent asthma, but they had had at least one severe asthma exacerbation in the prior year. They had to have a vitamin D lower than 30 nanograms per milliliter, and they had to undergo a run-in period where had to demonstrate that they were well controlled for their asthma on low-dose inhaled corticosteroids, fluticasone, over a 4-week run-in period. It was a 48-week randomized, double-blinded, placebo-controlled trial, again, to see where vitamin D supplementation could prevent severe asthma exacerbation in these high-risk children. And we also were interested in determining whether vitamin D could have some steroid-sparing effects. That is where we could reduce the dose of inhaled steroids in participating children, and where perhaps protective effects were stronger in viral-induced severe asthma exacerbations. The intervention was 4,000 international units per day or placebo. All participants received fluticasone according to their age, and the primary outcome was severe asthma exacerbations, where were defined according to American Thoracic Society, European Respiratory Society guidelines. And the main analysis was time to event or survival analysis. So these were the baseline characteristics of the participants. There were 192 by the time the study was stopped because of futility. The Data Safety Monitoring Board stopped the trial. And in general, the groups were well balanced with regard to most characteristics, save for sex, where there were more females in the vitamin D3 group, but otherwise well balanced. The vitamin D intervention did what it was supposed to do. This was a big concern for other trials like Beta that was done in adults, where we did accomplish the goal of making them sufficient. And in general, they were at 16 weeks, 94.4% of those in the vitamin D group had a level of 30 or higher, and about 40% in the placebo group. At 48 weeks, this was 87% for vitamin D versus 30% in placebo. And this is the main analysis, again, a survival analysis, time to first severe asthma exacerbation, and there was no significant effect of vitamin D supplementation with a hazard ratio of 1.13 and a confidence interval that included 1. We look at PCR-defined viral exacerbations and also found no difference, no evidence of a protective effect. And in terms of other outcomes where you look at days to a viral-induced severe exacerbation, the proportion of participants in whom we could have the dose of fluticasone at a midpoint of the trial, the cumulative dose of fluticasone, there was a non-significant trend to perhaps even a higher dose in the vitamin D group, and really no no difference in any of the outcomes, primary or secondary. And really, there were no serious adverse events in this study. So what we concluded there is in children with persistent asthma, low vitamin D levels fluctuating between 10, 14 to 29, vitamin D supplementation did not significantly prolong the time to severe asthma exacerbation. And this does not support the use of vitamin D supplementation to prevent asthma exacerbation in this particular group of patients. We still left a window as to whether vitamin D supplementation could affect severe asthma exacerbation in certain high-risk groups. For instance, kids in highly polluted areas, which I think is a question that has yet to be answered, and I'll show some data later on. Not only for vitamin D, but when you look for the data for other vitamins, vitamin C, vitamin E, trying to focus on single nutrients or vitamins to find an easy solution for asthma supplement appeal hasn't worked, despite experimental findings that suggested otherwise. This hasn't translated into consistent finding in human studies. This is at the general population level. Again, I'm going to talk a little bit about higher risk groups. So is there a role, or is potentially any role for vitamin D supplementation to prevent asthma or worse asthma outcomes in high-risk groups? And the reason this is a logical question is, think about asthma endotypes. So this is a slide from a nice paper published by Guy Bruxelles and Gerard Koppelman a couple of years ago in the New England Journal, looking at two major types of asthma. On the left side of the slide, you have T2 high asthma, which is characterized by airway eosinophilia, can be allergic or non-allergic. And then this group of T2 low asthma that has been far more poorly characterized, for which there is no specific treatment yet. And that includes T17 high and T2 low, T17 low asthma or post-severe null-acidic. But if you concentrate on T2 high asthma, you'll see the purpose of this review was to show how many monoclonal antibodies we now have to treat adolescents and adults with severe T2 high asthma. And the oldest is omalizumab, which blocks IgE. And then there are a number of other biologics that block different aspects of the pathways leading to T2 high asthma. However, if you go back in time and you look at the initial trials of biologics that were tested in all patients with asthma without any consideration to a phenotype or subtype, those trials were negative. And they were negative because, they didn't select the appropriate group of patients. Once patients were characterized by biomarkers, that is peripheral blood eosinophils, periostin, et cetera, then those trials started to show positive results. So it is also possible in certain subgroups, vitamin D supplementation may be beneficial. So the first group would be current smokers. So this is data from my colleague Gosli Tonhua and Nancy Lange, who was a postdoc at the Channing from 11 years ago, where they look at data from the normative aging study, which some of you may be familiar with. It's a study of veterans to look at the effects of age. Was established in 1963. Lung function was measured every 3 to 5 years, beginning in 1984. They stored serum and plasma samples when patients were examined. And for this analysis, they included data from 626 men who had a spirometry and 25 hydroxyvitamin D levels at 3 time points, starting with the period of 84 to 89 and ending in 95-2003. And what they found is that in current smokers, those who had a vitamin D level of at least greater than 20 nanograms per milliliter had lower or slower lung function decline over time than those who had low vitamin D levels, who had more rapid decline. The other subgroup that has been of interest is a pregnant woman who smoked. And unfortunately, there is still about, in the US, estimated that at least 7% of women still smoke while pregnant. These are recent estimates. And furthermore, depending on where they live, 40 to 75% of pregnant women are exposed to secondhand smoke. So this is a study from BDAR, the trial that I mentioned before. And what they did was they took 476 mother-child pairs. They had data on cumulative tobacco smoke exposure during pregnancy. They had plasma cotinine levels. In the mothers, they were measured at 10 to 18 and 32 to 38 weeks of gestation. In the kids, cotinine levels were measured at 1, 3, and 6 years. And the goal of this particular analysis was to look at whether vitamin D levels would modify any detrimental effects of secondhand smoke or active smoking. And so they had vitamin D levels at 10 to 18 and 32 to 38 weeks of gestation. And what they found is the summary slide is that, in fact, secondhand smoke, as you expect, decrease FEV1 ABC in these kids and increase airway resistance. However, when you look at this after stratification by vitamin D levels, using 30 nanograms per milliliter as a cutoff, those effects were seen in those with low vitamin D levels, but in those with sufficient vitamin D levels during pregnancy, there was no association between secondhand smoke or cotinine levels and lung function in the kids. And in fact, they validated, their plasma cotinine level report against self-report, and they were found to be accurate. And this is the data without a stratification by vitamin D. And in fact, cumulative tobacco smoke exposure was associated with lower FEV1, lower FVC, and high airway resistance when you look at all the kids. However, when you look again at this data after stratification by gestational vitamin D levels, what you see is that in those that where the levels of vitamin D were persistently high during pregnancy, there was no significant effect of tobacco smoke exposure and lung function. Whereas in those with persistently low vitamin D levels during pregnancy, FEV1 and ABC in the kids were lower. Similarly, but for another vitamin, Dr. Cindy McAvoy has been interested in studying whether vitamin C supplementation during pregnancy may modify the effects of secondhand smoke during pregnancy. So the original trial, again, this funded by NIH, was vitamin C to decrease the effect of smoking in pregnancy on infant lung function. So it's a double-blind, placebo-controlled, randomized clinical trial conducted at 3 centers in the US, Oregon, Washington, and Indiana between 2012 and 2016. And this particular analysis is a secondary follow-up analysis at age 5 years that included 213 offspring of pregnant smokers that were treated either with vitamin C, 500 milligrams per day, or placebo during pregnancy. And what you see is at age 5 years, the mid-flow rates like FEF 25, 75, FEF 50%, FEF 75, were all higher in the vitamin D C supplemented offspring than in others. This is also true for FEV1. Interestingly enough, in a secondary analysis, they look at recurrent wheeze at age 5 years. At age 5 years, you still cannot diagnose asthma with confidence. Some of these kids may end up having what we call transient wheeze, but still, it's a high-risk group. And again, vitamin C decrease the risk of wheeze in these kids, depending on where the mother was supplemented with vitamin C. And when you further look at this, it appears that early supplementation with vitamin C before a gestational age 18 weeks had a stronger effect. So again, in this follow-up study of a double-blinded randomized controlled trial with 213 offspring of 251 pregnant smokers treated with vitamin C or placebo, what was found is that forced expiratory flows at age 5 years showed an improvement in offspring airway function after supplementation of vitamin C versus placebo to pregnant mothers. There was also, a lower risk of wheeze at age 5 years. This suggests that vitamin D supplementation may decrease the detrimental or harmful effects of smoking during pregnancy on childhood airway function and respiratory health. And I don't think either the authors or myself are advocating that, this is what should be done, but acknowledging that there is a small subgroup of women that is not negligible, who are not going to quit smoking, and perhaps, this could be beneficial. Now, switching to air pollution, particularly traffic-related air pollution, we'll look at this in relationship to vitamin D in an observational study 10 years ago. So vitamin D is known to have some antioxidant effects, but no study at the time had examined where vitamin D insufficient may worsen the detrimental effects of estimated pollution on severe asthma exacerbations in school-age children. So we had data on proximity to a major road using geocoding. This is a surrogate marker of traffic-related air pollution, vitamin D levels and vitamin D insufficiency, and severe asthma exacerbations in a cohort of Puerto Rican children who at the time were 6 to 14 years of age. And this is the gist of the study. So we categorize the participants into 3 groups. The reference group is those who live further away from a highway, and we estimate as 441 meters, second to fourth quartiles away from the major road, and had a vitamin D level of at least 30 nanograms per milliliter. The second category were kids who either live close to a highway or had low vitamin D levels, but not both. And then the third category included participants who both live close to a major road and had lower vitamin D levels. And those kids had almost nearly 5-fold increased odds of having had a severe asthma exacerbation in the prior year compared to a reference group after adjusting for household income, treatment, and other covariates. So what this study, the findings of this study suggested that traffic-related air pollution and vitamin D insufficiency may have synergistic detrimental effects on severe asthma exacerbation in kids. And that perhaps, trials targeting this particular subgroup could be helpful. More recently, we went back to our clinical trial of vitamin D to prevent severe asthma exacerbations. The nickname, if you will, the abbreviation is VDKA, Vitamin D Kids Asthma. And we tested whether the estimated effects of vitamin D supplementation were modified by long-term exposure, that is exposure in the prior year, to fine particulate matter, PM2.5. in a post-hoc analysis from this multi-center double-blinded placebo-controlled randomized trial. And these unpublished data, we're preparing this paper for submission, but here you have the baseline characteristics of this particular post-hoc analysis. And in general, when you compare the vitamin D and placebo groups, they remain well-balanced, as was the case for the primary trial. There are no major difference in any of the relevant characteristics, particularly for PM2.5 exposure. Now, if you categorize the participants, not now by where they were in the vitamin D or placebo arms, but rather by high PM2.5 or low PM2.5, then you start to see some difference that perhaps would be expected. That is, kids who self-reported or whose parents reported their ethnicity as non-Hispanic Black were more likely to be exposed to high levels of PM2.5. Those at the Pittsburgh side of the trial, we have a problem with pollution in this city, no doubt. There was a higher prevalence of carrying exposure to secondhand smoke. And vitamin D levels at randomization were slightly lower, which perhaps, again, may be related to reduced sun exposure because of pollution. And this is a multivariable logistic regression analysis of the effects of PM2.5, depending on where the participants were in the vitamin D or the placebo arm. And what you see is that regardless of which covariates in general you adjust for, it appears to be there is an interaction term that is significant between vitamin D and PM2.5 exposure, with a trend for PM2.5 to not have detrimental effects in the kids who were supplemented with vitamin D. as opposed to the other group. This is after adjusting again for a series of covariates. But I think this shows the data more clearly. So here you have the data stratified by whether the kids had high exposure to PM 2.5 in the prior year or low exposure to PM 2.5. And now we're looking at the estimated effects of vitamin D on time to a severe asthma exacerbation. And what you see is that the kids who were supplemented with vitamin D had 59% lower risk of having a severe asthma exacerbation during follow-up than those who were on placebo. Whereas if you look at the other group, the group with low exposure to PM 2.5, there was no significant effect. In fact, there appeared to be even a trend for a detrimental effect. So that's interesting, right? And again, poses the question of whether selectively vitamin supplementation may be beneficial for groups who may be exposed to secondhand smoke, in-utero smoke, or higher levels of air pollution. This would have to be tested in other studies where it's a randomized control trial or other study designs, but I think it's an interesting question. So what about overall diet? Well, a healthy diet, and here a Mediterranean diet is used as an example, by no means is the only one, has antioxidant properties through vitamins, anti-inflammatory properties through micronutrients. There is high fiber, there is low energy intake. This in turn has some potentially beneficial effects: decreased ROS, decreased oxidative stress, decreased systemic and airway inflammation, a healthier gut microbiome, and decreased weight gain and decreased insulin resistance, which perhaps could lead to reduced asthma incidence with better lung function and better asthma control. And in fact, this has been consistently shown in a multiplicity of studies around the world. These are meta-analysis of data for childhood asthma from multiple sites, and the diet above is non-Mediterranean and compared to Mediterranean diet. And the Mediterranean diet is shown to have 15% lower odds. It's a potential protective factor against, I think this is Swiss. And then the results for asthma are very similar. So for Mediterranean diet, you see about a 14%, reduced odds of asthma. Now, I told you about the importance of understanding that asthma is a heterogeneous syndrome. There are different phenotypes. There is great interest in endotypes. We're also doing work in that space. I have no time to discuss that during this topic, but but we're doing that. And this is an analysis that we did 6 years ago with my colleague Yu-Ying Han, and this is data from the National Health and Nutrition Examination Survey, or NHANES. These are adolescents on top and then adults at the bottom. And the analysis is looking at quartiles of something called the Dietary Inflammatory Index, which can be calculated using, for instance, a food frequency questionnaire, versus the risk of asthma in adolescents and adults. And what we found, which is interesting, in kids, you see that as the inflammation, the dietary inflammatory index increases, the score increases, which is again pro-inflammatory, there is a greater risk of asthma in those who have high FeNO, but really no effect in those with low FeNO. In adults, you see that the effects of this dietary inflammatory index score are seen in those with low FeNO, but particularly, again, more strongly for those who high FeNO, suggesting perhaps that diet influences T2 high asthma more strongly than T2 low asthma, if you will. This is a similar analysis, and here where we look at where adults in the Hispanic Community Health Study, or Study of Latinos, which is a study of 16,000 Latino adults in 4 US cities. And on top, you again have this dietary inflammatory index. Again, the higher the quartile, the more pro-inflammatory the diet. And in these adults, you see that even adjusted for Latino background or subgroup, you have an association between a higher dietary inflammatory index and the risk of asthma, current asthma, and particularly current asthma symptoms. The index on the bottom is used in cancer studies and is supposed to do the opposite. That is, the higher the quartile, the more beneficial, and there we didn't see an effect. We also look at these with relationship to lung function. And when you look at all participants for this analysis, we're 11,817, you see that a dietary inflammatory index was inversely associated or associated with lower FEV1 FVC, whereas the other one, the good diet, if you will, indicator shows the opposite effects. You know, the higher the score, the higher the FEV1 FVC. The effects were stronger in participants without asthma. I think that's related to sample size. There were many more participants without asthma than those with asthma. More recently, we also look at this in a longitudinal study of Puerto Rican kids that we have been following over time. So this study we call the prospective study of Puerto Ricans and asthma. At baseline, the kids were 6 to 14 years of age. They participated in a study called PRGO. And then we saw them again at a second visit in another study called EVA-PR about 5 years later. And we had data on a dietary score, and for simplicity in this table, I'm showing you what we categorize as a healthy versus unhealthy diet. So again, there were 2 time points, 2 visits. On the left side, you have the estimated effects on asthma, and on the right side on severe asthma exacerbations. And for kids who had reported an unhealthy diet at both visits, there were 3.38 higher odds of having asthma at the second visit. And at the second visit, 2.7 increased odds of having had a severe asthma exacerbation in the prior year, even accounting for steroid treatment and many other covariants. So in summary, for a diet part, what I can tell you is at the general population level, when you look at everybody with asthma, I don't think that you can recommend a single nutrient or vitamin to prevent or treat asthma. Again, there are 2 subgroups that are of interest who may benefit, but I think we need more data, and those would be smokers or people exposed to secondhand smoke and people living in highly polluted areas. Those would be 2 groups. But apart from that, a healthy diet is the best recommendation you can give to your patients, with high consumption of fruits and vegetables, low consumption of saturated and trans fats. One has to remember that dietary habits have direct effects, and I show you that in that slide, the antioxidant effects, etc. But they could also have indirect effects through a healthy body weight, a healthier gut microbiome, and all of those could have beneficial effects on asthma. So again, this is just to remind you of potential pathways, if you will, through which a healthy diet may protect against asthma and worse asthma outcomes. So what I presented you today is a result of multiple collaborations, you know, with different groups over time. So I'm very grateful for that and the support of the NHLBI. And this is the picture of our hospital during winter time. So thank you very much. I'll try to answer any questions you may have.